Hey everyone, welcome back to another episode of Doctors Go Live. I am Nina Sharil Khan, your host for Doctors Go Live. Today, we are talking about chronic post-surgical pain. Now, let us know if you're tuning in right now, where you are tuning in, and share with us what would you guys like to learn in today's episode. Chronic post-surgical pain. Now, if you share this video out, you get to take part in our Doctors Go Live quiz happening right at the end after the Q&A, where you get to win some basic health screening vouchers up for grabs. So if you want to win those vouchers, pay close attention to what our doctor for today is sharing. Okay. Now, all this is happening live right here, right now on Doctors Go Live with me, Nina, and our special guest for today, Dr. Rushin Maria Dass. Okay. Now, when you have surgery, your post-surgery recovery can be a debilitating experience, especially if there is a lot of pain. Now, while there is pain relief, it's not a one size fit all. So, what is chronic pain after surgery, and what are its causes, and what are the different ways to relieve the different kinds of pain? So, we're going to look into all this right now, happening right now on Doctors Go Live. So, if you know somebody who's about to go into surgery, or someone who's had surgery but is having an unpleasant experience with their recovery, or if you are like me and you want to avoid pain at all costs, then today's episode is the one for you. All right. So also, if you think this is such an important topic, such an important subject, and you would love to share it with your friends and your family, feel free to do so. Share it out on your social media posts, tag your friends, and follow us. Because this episode can definitely make a difference to somebody today. All right. So now let's take a look at this video.
I'm Dr. Rushin Maria Dass, an anesthetist and pain physician from Columbia Asia Hospital, Bukit Rimau. In the next episode of Doctors Go Live, I'll be speaking about chronic pain in general, but more importantly, chronic post-surgical pain. In this episode, I'll be talking about the causes, incidence of this type of pain, and also the treatment options in terms of pharmacological and non-pharmacological as well. Catch me on Wednesday, 24th November at 3 p.m. See you then.
Welcome back, ladies and gentlemen, to Doctors Go Live today. And today we are talking about chronic post-surgical pain. Now, although we have all experienced pain, and despite it being one of the most common symptoms people seek medical help for, it is also one of the one which is most misunderstood. So especially pain that comes after surgery. And because this type of pain, ladies and gentlemen, tends to last longer than usual, making recovery can be an unpleasant experience. Okay, so to help us understand better chronic post-surgical pain, we've got you the expert from Columbia Asia Hospital Bukit Rimau, consultant anesthesiologist and pain physician, Dr. Rushin Maria Dass. Dr. Rushin, thank you for joining us today. And also, while waiting for Dr. Rushin, thank you so much for joining us today.
Hi. Thank you for having me.
Okay, fantastic. Now, just to remind our guests today, right at the end of the show, you definitely want to enter our Doctors Go Live quiz, where you get to win our basic health screening vouchers up for grabs. So you definitely want to listen to what Dr. Rushin has to share. Now, if you have any questions whatsoever, please feel free to share, to ask us in the chat, and we will address this right at the end of the session. All right. So, Dr. Rushin, let's start from the very beginning. Let's talk a little bit about you. Can you share with us a little bit about you, and what is it that you do right now?
Okay, I am an anesthetist. I have been practicing as an anesthetist for the last 8 years. And what I did was I first specialized in pain medicine. So I had an interest in pain medicine because when I was in my undergrad study, I did my initial degree in Unimas in Sarawak, in Kuching. Mm-hmm. And when I was there, I saw many patients who were in a lot of pain, especially cancer patients. And that actually sparked an interest in pain medicine later on. Yeah. So as I became an anesthetist and I knew that this was an option for me, so I went to further study in pain medicine. So that's how I went into this field.
Wow. So that's how it all started, right? That's very, very interesting. Now, let's get straight into this then. Before we start, Doc, I think let's get everybody on the same page. When we talk about pain, what do we mean by pain? Yeah. Okay. And I think we can have the slides on as well.
So if you look at the definition of pain, this is the latest definition of pain by the International Association of the Study of Pain. There's a pain association, International Pain Association, which comes up with definitions and the type of pains and all this, and they do a lot of research in pain. And the latest definition says it's an unpleasant sensory or emotional experience associated with or resembling that associated with actual or tissue, potential tissue damage. So what it tells you here, this whole definition is very confusing actually. It confused me that from the time I started doing pain, and every time they change the definition, it continues to confuse me. But you sit down and just look at it and say it's actually very complex and subjective phenomenon. Okay, what's pain to you and what's pain to me is very different, and it's actually a personal experience that to varying degrees of biological or even psychological and social factors. So there are a lot of factors that defines pain in a person. It's very different from me to you. So that's basically what it means. But in a medical diagnosis, all right, when it comes to medicine, if one is having pain, it's a symptom of an underlying condition most of the time. But that doesn't mean that you have something wrong with you. So when it comes to chronic pain, you have this is where the confusion comes. We try to differentiate: is there something wrong with a person, or is there something not wrong with a person? So that's I think that's how pain is defined as now.
Wow. Okay. So the definition of pain is confusing. Got it. So as long as the layman term understands it, that's easy. Okay.
Yeah.
Got it. So when we talk about pain, are there different types of pain, and what are they?
Okay. So if you look at the next slide, so you have acute pain and chronic pain. So, and also it can be your acute pain can be chronic pain can be further subdivided into the type of pain that someone feels. Right. So then you have to differentiate whether this is nociceptive, neuropathic, or you even can have both as well. And sometimes this nociceptive pain can be either visceral or somatic. What does it mean by visceral or somatic? I will further explain in a while. So acute and chronic means, acute means is what you feel straight away. What you feel, when you have a cut in your hand, and what you feel, you have that sharp pain, that dull aching pain that comes initially. So that's the acute pain that you feel. And once healing occurs, acute pain should go away. All right. So it goes away. But in chronic pain, what happens is the pain it prolongs. Someone has the pain, more than, usually the timeline is always more than 3 months. So if you're having pain for more than 3 months, then it's already considered chronic pain already. There may be an underlying cause for it, there may not be an underlying cause for it. So chronic pain is different than acute pain. So so then we talk about nociceptive and also neuropathic pain. Now nociceptive pain is how the patient feels the pain. So if say I have a dull, aching, throbbing pain, a sharp pain, those are what you call nociceptive pain. So if someone punches you in the face, you feel that, the dull aching pain and all, that's nociceptive pain. But if neuropathic pain is because of some disorder with your nerve, you cut the nerve or the nerve is damaged, then you feel some kind of pain. So if someone has a back pain and he has that shooting pain, now like the electric shock like a pain, that's neuropathic pain. That's because your nerves are involved in and that's the type of pain. So what is neuropathic pain is very distinct. We can tell you electric shock sensation, burning sensation, all right? And then you've got tingling sensations. Sometimes you hit your elbow and you feel that tingling sensation. That's because you hit your ulnar nerve somewhere. So that's why you get that tingling sensation over your hand. So those are types of neuropathic pain. Yeah. And visceral and somatic means from where it's coming. So if I have pain from an appendicectomy, appendix is inflamed, so you have pain in your abdomen, right? So that's visceral pain. It comes from the organ inside. The somatic pain is actually from the outside. Yeah. So the visceral and somatic pain are types of nociceptive pain. Actually, it's a subcategory of nociceptive.
I see. Okay. And what is somatic pain? Sorry, you said again?
Somatic is usually from your outer layers, from your skin
okay. And visceral is inside.
Inside, yeah.
Okay, got it.
So
thank you so much, because I did not know there were so many different types of pain. Okay,
yeah.
So why does this happen? I mean, why do we feel pain, or rather, how do we perceive pain?
Okay, so if you look into the next slide, so this is how the pain pathway. Okay, how do one perceive that how do you feel pain actually? Basically, so everything happens in the brain. You got no brain, you got no pain. That's what, okay? But it starts, okay, say if you knock your, look at the picture here, if you knock your foot, okay, so what happens is there's some inflammation that goes on in your foot, and they release some substances, and also starts to, the first thing that picks up any noxious stimuli would be your nociceptors. This is the pain receptor in your peripheries, and from there it actually transmits impulses, electrical impulses, to the spinal cord, where it's called the dorsal horn. So that's where the pain signals transfers to the spinal cord, and then the signal goes up, and all this happens in a matter of milliseconds. Actually, it's very fast, all right? So it goes up to your brain, okay, and it synapses in the brain as well at the thalamus, and then it goes up to your sensory cortex. Okay, in your brain there is the motor cortex where you have your movement. There's a sensory cortex, so that's where you feel things and all. So that's where it goes, and then the signals are sent back for a reaction or reflex or whatever not. So that's how you feel pain. It's actually when the whole, if you can see the line, it goes from your foot right up to the spinal cord, and then up to the brain where pain is perceived. So this is the pain pathway in general, basically.
Right.
So
we got
it feels pain because the brain tells you it's pain. That's it.
Right. So basically, no brain, no pain. Got it.
Yeah.
It even rhymes, Doc. Fantastic. Okay, so this is pain in general. But when it comes to chronic post-surgical pain, what is it?
Okay. So that's the outline of my talk today. I will define chronic pain and talk about the incidences, the risk factor, pathophysiology in a gist, tell you, and pathophysiology basically why does it happen and how does it happen, what changes in the body, it goes on in the body, the clinical presentation of how one presents with chronic post-surgical pain, how to prevent it and how to manage it as pain physicians, what do we do to manage it. So
okay, fantastic. So we're gonna look into all this. So but before that, when did people actually start to take this sort of pain? How did it all start?
Okay, so chronic post-surgical pain, really, actually, if you look at it, is very new. In fact, the definition was defined only in 1999. Okay, and it started in this paper by an American
war veteran, is it?
War veterans, yeah. So it's an American, this guy by the name of Sherman. Okay. He looked into this pain, chronic pain, phantom and stump pain among American veterans. So those who had actually amputations, right? And what happens is a lot of them had 78% had phantom pain, and only 1% had lasting benefits from any treatment or form for this type of pain. So what is phantom pain is actually if you have your leg amputated, all right, but you still feel the leg over there and it's painful, right? Even after a number of years, even though that leg is gone, but the pain is still there. Okay, so this is what they continue feeling. So if this is a form, phantom pain actually is a form of post-surgical pain. All right, and in 1998, so another paper written by these guys in UK, what they did was they actually looked into 50 pain clinics throughout the UK, and looking at 5,000 patients in this, about total of 5,000 patients, they looked into it, and they found that all these patients in these chronic pain clinics, about 22% of them, 22.5%, their chronic pain is actually contributed by a previous surgery, or 18% has some previous trauma or something like that. And this was actually the first actual paper on chronic surgical pain, which actually prompted many more studies that came in the early 2000s. Yeah.
Wow. So it's very, very new, only in 98. Yeah. Okay. Yeah. I can see why you're interested in this. Definitely. So when we talk, back to my question earlier, when we talk about chronic post-surgical pain, what do we mean by it?
Okay. So this is the 1999 criteria. So when they said it's pain that develops after a surgical procedure, all right? And it should last 2 months, at least 2 months duration. That means after the surgical procedure, after 2 months after that, you still have that pain. Okay, after healing has occurs and all, you still have some sort of pain that's not going away, some nagging pain that that's disturbing you. And but when you look at this pain, it should not be from other causes. The two most notable causes is actually a recurrence of cancer or an infection. So you have gone for surgery, say, because of a skin infection, all right, and you have debrided and cleaned it up and everything, but then you still have pain. Now, you have to start thinking whether this is pain from something else, or is it pain from that initial infection which is not cleared properly, or is there a cancer there that has spread and a recurrence over the site of surgeries? All the things you have to rule out first before you say this is chronic post-surgical pain, right? And yeah, so you really have to actually explore that pain. Take a good history, like someone like doctors like us, and we have to take a good history and explore this pain and make sure that it's not from a pre-existing problem, okay? And this pre-existing problem has to be excluded.
Okay, fantastic. Okay, before continuing, I just want to say welcome everyone. If you've just tuned in, today we are talking about chronic post-surgical pain with Dr. Rushin Maria Dass. We've just defined what chronic pain is. Next, when did people actually start to take this sort of pain seriously? How did it all start? Yeah.
Okay. So when you look at the epidemiology, if you look at studies, many studies have come up from chronic post-surgical pain, and a lot of them report an incidence of 10 to 15% of patients have pain after 1 year after their surgery. And you have to know, and they found that even different types of surgery have different types of incidences. Certain surgeries have more people having chronic post-surgical. The incidence of chronic post-surgical is more. And one particular surgery that you have with a lot of chronic post-surgical pain is amputations. Okay, if you look into the next slide, so you see certain surgical procedures, they have these certain pain syndromes that come with it. So there's a range of incidents because different papers shows different percentages. So like say amputation, those who have phantom limb pain is as high as 30% up to 81% in certain papers. Because different papers have written different incidences. So I just put a range there. Stump pain is the pain over the stump where they have, when they amputate the leg and they have a stump there, right? And that stump may be painful. So pain syndrome from amputation can be a phantom limb pain, a stump pain, or different those type of things. So what are the incidences there? The other one notably is breast surgeries. If you look at breast surgeries, post-mastectomy. Mastectomy means it's removing the breast, right? So most post-mastectomy pain over the site of there is about 11 to 57%. Phantom breast pain, that means someone feels the breast is there when the breast is actually removed after that. So they feel that what they feel that breast is there, that part is actually painful. Sometimes they have post-breast surgery arm and shoulder pain. This is also very common. We have seen in the pain clinic as well, 12 to 51%. The others are not so common. The other one is like in hernia surgeries. There's another one is very common. About 56% of patients feel some form of chronic pain after the surgery. So 2 months after that, they feel some form of chronic pain. Thoracotomy is another one where they go for open heart surgery, lung surgeries, and all this, where they actually put a retractor over the, you stretch your nerves and all this, so you get that chronic post-thoracotomy pain as well, more than 50%. So these are some of the surgical procedures which are commonly, but doesn't mean that any other surgical
you are going to get it.
Yeah.
Right. Okay.
So
got it.
The other thing is orthopedic surgeries have 3 times more common. They are 3 times more common to have chronic post-surgical pain. Any orthopedic surgeries as compared to other surgeries as well. So these are the data that we have got so far.
So when you say orthopedic surgery, which part is that?
Orthopedics in general, anything with your hands and foot and legs, your bones. Yeah.
Right. Okay. So that's 3 times more. Okay. Got it. Okay. So those are the kind of surgeries where you see this happening. Yeah. So what are the risk factors to it?
Okay. So there are a number of risk factors, many risk factors. They can divide it into what before the patient goes in for surgery, what are the risk factors you can look into, okay? During the surgery, what the surgeon can do or the anesthetist can do to prevent this type of chronic post-surgical pain. And also post-operative factors as well, they are certain risk factors. But the most consistent factor that they have found that if the patient has pain even before surgery, okay, for instance, they have cancer and they have a lot of pain before that, and it was not well controlled before the surgery, all right? And they have a higher chance of getting chronic post-surgical pain. Or if after surgery, your pain is not well controlled, all right, especially pain on discharge from the hospital, then there's a higher chance of getting chronic post-surgical pain. Right. So
Wow. Okay, got it. Can you explain more, because you mentioned that it can be divided into pre-operative, intraoperative, and post-operative. So can you explain more about pre-operative risk factors?
okay. So if you look at the pre-operative risk factors, there are
This is before surgery, right?
before surgery, yes. So before surgery, like I said, if you have presence of pre-operative pain, which is like a moderate to severe pain for more than a month, especially if it's more than a month, you'll be having a lot of pain before surgery, and it's not well controlled, that this is a very consistent risk factor, right? And then a younger age person, female.
Why female more? How much more? Do you have a percentage of that?
I don't have
Just wondering.
actual percentage, but yeah, they found younger female patients have higher chances of CPSP. And genetic predisposition is one thing. This is a very it's not very new, but it's up and coming. They found certain genes that or certain mutations in certain genes. People who have certain mutations in certain genes that have this tendency to get chronic post-surgical pain, right? And then if you have psychological factors, that means if you are someone with a depression or an anxious kind of person and all this, you tend to have all these, you tend to have higher chances of getting CPSP. But again, all these factors, it's nothing really proven. Especially the psychological factors, it's not really proven, but we just tend to notice a little bit more there. And it's written in the books. There's no proper study saying the only most consistent factor is presence of preoperative pain. Other factors like social and environmental factors as well. They said, if you got over solicited partner or family, or they notice that these patients have CPSP. So what does it mean by over solicited partner or family? Someone who's someone who's basically manja you during the pre-op, or who takes care of you.
Got it. Overly takes care of you.
Yeah, a bit too much sometimes you think.
A bit too much. Yeah, I would be stressed out, so I can understand why it continues, that sort of thing. And also psychological factors, as though people going through psychological factors don't already have enough on their plate. So yeah, something to think about. So maybe it's something to do with psychology, right? That kind of thing.
Yes.
And how we manage and perceive pain, like what you said. So this is pre-operative. What about the intraoperative factors?
Okay. So intraoperative factors, I think if there's a chance of the surgical technique someone uses, how they approach to doing a surgery, the experience of the surgeon, it definitely counts. All right. Avoidance of intraoperative nerve injury, I think this is a very important point. When a surgeon does a surgery, they look for certain nerves that they know. When they look, they know the anatomy very well, and they know, okay, this nerve passes here. Let's look for it and push it aside, not transect to the thing or injure the thing. Sometimes when you're retracting during surgery and all, if you pull onto the nerve too much, and that's how these things start coming out. So. And then the use of minimally invasive surgery. So they have noticed that if you use, if you do surgery in a laparoscopic way, instead of using a huge scar there, put in 3 or 4 holes and try to do the surgery, and this has reduced they find that this reduces the incidence. So if the length of surgery is more than 3 hours, then the chances of having CPSP is higher. If the person goes on multiple surgeries, right? They go on first surgery and they subsequently have to go for multiple surgeries in the same setting, in the same hospital. I mean, after a few days, they go in again, multiple relook and all this. So those people have higher chances of getting CPSP.
Okay, interesting. Okay, and when we talk about the pathophysiology, please correct me if I'm pronouncing this right. Neuropathic, is it pain?
Yeah.
Yeah. Yes. Nociceptive, sorry.
Okay. So what happens is remember I told you there are a few different kinds of pain. So basically nociceptive or neuropathic pain. So nociceptive is what you feel, that dull, aching pain and all. Why do you feel that? Is because of some, myofascial means it's a muscular issue or something like that. You have some muscle issues. Now you have this type of nociceptive pain that can come up. Any inflammation, or swelling of the tissue or pressure on the tissue, any traction that's causing that's on there, you can feel this nociceptive this type of pain. That's what it means. These are the causes of the nociceptive when someone have nociceptive pain. So if someone is having CPSP and you have this nociceptive pain, why do they have it? It's because of these are the causes, like any inflammation or anything compromising the blood supply to the area, or is there swelling there? Edema means swelling over the area. So that's what this slide means basically.
Okay, got it. And if you look at the next slide, I think it goes into intraoperative factors.
I think this is a repeat of the other slide earlier.
Oh, okay, got it. And pathophysiology, neuropathic pain. Okay.
Okay, so now why did someone? Okay, so most of the time when you have chronic post-surgical pain, you have a lot of neuropathic pain actually. Rather than nociceptive pain, you have a lot of neuropathic pain. And
which is the nerve pain, right?
You nerve pain, yeah. So why do people feel this nerve pain? It could be from the damaged nerve and all this. Okay, but why do you have prolonged pain? So then you want to know, why does the pain go on and on? Then you got these things called the peripheral sensitization and the central sensitization. Peripheral mechanisms means what happens outside the spinal cord and the brain. Okay, and central mechanisms is the spinal cord and the brain. Yeah. So when you look at the pathophysiology in the terms of the peripheral side, then there's peripheral sensitization, okay? And the central side is called central sensitization and spinal cord neuroplasticity. These are the main things that happens there to cause this prolonged pain. So if you go to the next slide, I can tell you what these are. So this is what peripheral sensitization is. You have a tissue injury, and if this tissue injury is already healed, but the substances that it releases is continuing there. It sensitizes the nerves around the area, which is continually going to cause pain. It's going to give you continuous pain. So you can see this. This is a very technical slide, like I said. What it does is, at the periphery, it sensitizes your nerves, and that's why you continue feeling that kind of the pain that you're supposed to feel in CPSP. Okay.
Okay,
so these are so what this slide shows you is there's all those the ligands and all this inflammatory soup that happens in your peripheries that sensitizes your nerves, that gives you that continuous pain.
Okay, got it. And I think there's another slide which is similar to this. Yeah. And what about this one?
What happens is, it's the same thing, but now what happens is this peripheral sensitization, if it's left unchecked, it starts to sensitize your areas in your central sensitization. So then it will cause some upregulation of receptors in your spinal cord, and they will start to increase the neurotransmitters in your spinal cord, and this is called central sensitization. And what happens is you start feeling more, you start to perceive this as more pain. So what happens when all these happen is peripheral sensitization and central sensitization happens. So if you get this thing called hyperalgesia and allodynia. Okay, so what's hyperalgesia? Hyperalgesia means if I touch you normally, all right, if it's a normal touch, you should not feel pain. But if this person who is already sensitized and all, you touch them in a normal pain, they feel as if they perceive it as pain. Yeah, so that's hyperalgesia. Actually hyperalgesia means what if it's just a simple prick, it's supposed to cause you not so much pain, but they tend to,
it's expanded. It feels more.
So much. Allodynia is what I explained earlier. Is a normal touch, but they perceive it as pain. Yeah, that's what allodynia is.
Got it. Okay, got it. And what about post-operative risk factors?
Okay, so
okay.
So the post-operative. Yeah, I think the slides are missing there. There are post-operative risk factors. Also, if there's one, like I said earlier, like the pre-operative risk factor, it has ongoing pain which is unchecked. That's another risk factor to continue to have CPSP. So this is one major factor. Is after surgery, if the pain is not well controlled, these can continue to have. They can continue to have. This is a higher risk to get CPSP later on.
I see. Okay. Yeah. So in terms of pre, intra, and post, where does the main challenge happen? Actually, would you say for post chronic post-surgical pain? Usually it comes from where? Pre or
Okay.
post, would
All
you
right.
say? Just wondering.
You mean which has a higher risk factor, right? You're saying?
Yeah.
Yeah.
Mm.
Okay. To me, I think all of it is equally as important.
I
To
see.
me,
Okay.
yeah. So to me, if you look at the preoperatively, if you really have to control your pain well
Mm.
before they go in for surgery. All right. And during surgery also,
Especially after discharge, right? You mentioned?
yeah, especially if you have pain on discharge. If you have pain on discharge,
Mm.
that's one thing you have to that's I think is a high someone will
Chances.
be higher risk of having CPS. Yes,
Okay,
and
got it.
so even I think it's not just looking at preoperative or intraoperative or postoperative. Everything has to be sorted out
Mm.
and
And managed
looked
well.
at and managed well. Yeah, these three factors.
Okay. Okay, so let's look at the clinical presentation. How do people know whether they have chronic post-surgical pain or not?
Okay, so the presentation of this chronic post-surgical pain can vary, and
Mm-hmm.
the degree of pain one has is also different. Different. So sometimes some patients who actually have some form of chronic post-surgical pain, but they don't present because the pain doesn't bother them. They have some numbness, but it's
Mm.
okay. They can tolerate the thing, and they just don't say anything, or they just don't see anybody about it. But so some patients have the other extreme where they can't tolerate the pain, and that's how they end up in the hospital and all this. So the presentation can vary. Usually, is at around the site of the surgery. All right, it can be neuropathic kind of pain, or it can be nociceptive, or even both. Okay, they can have both kind of pain, neuropathic or nociceptive, and this pain can radiate to the area away from the operating site as well. Eventually, okay. As
Mm-hmm.
peripheral and central sensitization occur, all right, and you can have a lot of radiation in the pain. And one thing we really have to differentiate, the red flag means something you have to stop and think now whether this is an infection, is a recurrence. That is, you really have to think about it.
Tell the
And
difference.
stimulus, sorry, say again?
You got to tell the difference. Really
You
know the
have to tell
difference between
different
the two.
because
Mm-hmm.
you don't want to say label someone to have chronic post-surgical pain, and by the actual fact they're actually having a recurrence of their cancer. Then the treatment
Right.
will be different. Would have missed the boat, and they may have got
I
worse with the cancer. So
see. Okay.
yeah, so that's why it's very important to make sure that the scans are repeated and and looked into and all these things. Yeah. And this type of pain is a stimulus-induced pain. That means you touch them or you stimulate that area, you may have more pain than usual.
Okay, so all this we can tell if we see all this whether somebody has it or not. Let's talk
Yeah.
about prevention. Can we actually prevent chronic post-surgical pain, and if so, how?
Okay. So then, when you want to prevent it, look at the risk factors back again. So this is a table that shows you what the risk factors were earlier what I've explained earlier. So you look at the preoperative factor, but what's the main thing you want to do is, if you look into the next slide, how to prevent it.
Okay, let's take a look at how to prevent it. The next slide, please.
Yeah.
Okay.
So a good pre-operative analgesia and minimization of your surgical tissue injury will remain the important goal for anesthetists and surgeons. So as an anesthetist and the surgeon, you want to make sure the patient well controlled, and you want to use a smaller scar or do laparoscopic surgery and things like that. These are the goals we have in order to make sure that the patient doesn't develop CPSP towards later on. And we want to treat pain well before surgery and after surgery, right?
Mm-hmm.
And make it a point to look for to isolate nerves, especially when you're doing surgery, to avoid intraoperative nerve injuries, right? Minimally invasive techniques is what I told you, laparoscopically and all these things. Education on CPSP, that means patients, surgeons, anesthetists, nurses, and allied health. So I think this education part is really important. I mean, if sometimes we notice some people complaining about patients, it's just a small scar, but he's having a lot of pain. I think it's okay. You don't have to give him some more medications or something like that. This is the type of perception people have, because even though if a small scar for you may not be so painful, but the other person, for him, is very painful. So if he's in pain, we should treat. We should not just say pass off comments like that and all. So education on CPSP, especially to allied health nurses and all, is very important, I feel. Yeah. And then you need
psychological issues.
Yeah, so psychological issues is another thing that we have to address. So if someone has depression, anxiety, even pre-operatively, I would refer them to a psychologist or psychiatrist. Yeah, okay. to make sure all these things are sorted, before they go in.
Yeah, because it seems to be connected. Yeah, so it makes a lot of sense actually. That sort of thing. Very, very interesting, I have to say. So let's talk. Can we talk more about regional anesthesia?
Okay. So why I put this slide in is to tell you the benefits of regional anesthesia. Now, what is regional anesthesia? It's actually it's a type of anesthesia where we numb a large part of the body. Now, we can have this regional anesthesia central neuroaxial block or peripheral nerve blocks. Okay. So central nerve blocks are like, when you do your epidurals for your labor, okay, those are central nerve blocks. So this is also part of regional anesthesia, except it's done somewhere near your spinal cord. All right. Or if they're going in for surgery, we do a spinal block on them. That's also regional anesthesia, but it's done in the spinal cord level. But you also can do regional anesthesia in, say, your upper limb. So if you're going in for a hand surgery, instead of putting them under general anesthesia, we inject the nerves, which is somewhere around your shoulder over here, and you get a nice numb area, and they can proceed surgery without even going under general anesthesia. Now, why is this important? Because to me, as a pain physician, I feel that regional anesthesia has come a long way since those days, and he has proven to show that it has superior perioperative pain control in some human studies and also animal studies, but in terms of preventing CPSP, I think the evidence are still not there yet, not so strong yet. But to me, I think if you're going to control your patient's pain well, you want the good method, right? So this is a good method of regional anesthesia. So whenever you're going for surgery, you would want to think and consider regional anesthesia. Of course, there are definitely risks and complications that can happen with regional anesthesia. You hear about it, you might get scared about it. But with the advent of nowadays we use ultrasound and we use nerve stimulators and all this, it's become much more safer than those days. Yeah. So consider regional anesthesia when you're going in for surgery. I think if you have more papers to study its association with chronic post-surgical pain, it may prove that it helps to prevent CPSP in some way or another.
Wow. Okay, got it. Interesting. Okay, so Doc, let's say someone in our audience perhaps is scheduled to go for surgery. How do you manage pain after surgery? We need to manage it even before, right? Is there anything you can share with me? Or what are the different ways you use to relieve the pain?
Okay, so that's acute pain, all right? So if after surgery, we can manage it in different ways using pharmacological ways. Pharmacological medications that we give you, either IV, oral medications and all. We can give you regional anesthesia, like what I've told you, to manage post-operative pain, all right? We can use, non-pharmacological ways. Non-pharmacological is simple things, physiotherapy, elevation of your limbs which have went for surgery, all right? And all those things, yeah. And then ice and rest and all this. Those are non-pharmacological ways in an acute pain setting, all right? So those are the main ways of managing them. Now, but what about CPSP? When you have chronic post-surgical pain, then the management becomes different, okay? So what is the aim when someone comes when it's already an established diagnosis of chronic post-surgical pain? My aim is not so much of pain control anymore. My aim is to get the patient functional back again, right? So if someone has a severe form of CPSP, they can't go to work, they can't sleep, they can't move around and do what they normally do. So then my aim becomes different. My aim is, this is chronic pain. Chronic pain, that means pain is going to last a long time. So that's why our aim is not so much of pain control anymore. Pain is more a functional outcome. We get the pain down to a certain level, all right? so that the patient can go back to his normal daily routine, right? So, and the approaches we can use are pharmacological approach, non-pharmacological approach, and interventions, all right? And all these have to work hand in hand, right?
I see. Okay. So let's take a look at the different types of management then, starting with pharmacological management.
So there are first line treatment, there are other therapies basically. Okay, so so in terms of chronic pain, especially if you have a lot of neuropathic kind of pain and all, and then the first line treatments are usually anticonvulsant. They call gabapentin, pregabalin. I think if those who are very familiar with chronic pain, they will know that these are the things. So anticonvulsants are actually used in patients who have fits, patients who have seizures. Those are the drugs. So these drugs were initially used for those patients, but at the end they found that anticonvulsants works well with those who have chronic pain and neuropathic kind of pain. So how does it do is actually it stabilizes your nerves and so that you don't feel so much of the pain. Tricyclic antidepressants, they are actually initially amitriptyline and nortriptyline. They are also used as antidepressants, initially, but when they also found that it helps with neuropathic pain or even chronic pain. So how does it do is actually it plays with your neuroscience. It actually increases the neurotransmitters in your spinal cord, and that's they basically play with your perception of how does the one perceive pain before, as I told you, right? There is a pathway where the how someone feels pain, isn't it? The first few slides earlier. So that how did someone feel pain? So this is where it acts. The tricyclic antidepressant acts on the spinal cord. There's SSRIs, duloxetine and venlafaxine. They are kind of antidepressants as well. They work well for chronic pain as well. It's used in it also acts in the spinal cord level. Tropical lidocaine and tropical capsaicin, these are topical medications, right? Local anesthetics for the area. Yeah, you can rub it on the area or put a patch over the area of pain, right? Other therapies are the things that we all use in acute pain as well. Things like paracetamol, NSAIDs, like Voltaren and Celebrex and Acoxia. We use it for acute pain. Sometimes we use it for this type of chronic pain, but very rarely. I put a big I put an asterisk on strong opioids. We generally don't use strong opioids in chronic post-surgical pain. Strong opioids are things like morphine, oxycodone, and all. We don't use this type of pain because of its long-term effects of addiction and all these problems. So we tend not to use all those. Yeah.
Okay, got it. Let's look at another way to manage pain. I think interventional pain, right?
Okay, interventional pain. This is basically what do you call it? It's more invasive kind of treatment rather than pharmacology is using drugs and all. These are more like nerve blocks and sometimes even using pulse radio frequency to actually modulate the nerves. All right. So it depends. Sometimes if you look at certain chronic post-surgical pain, if you can find an entrapment of the nerve, say the scar over there, if they've done an operation in the scar and there's a nerve that's entrapped in the scar. So sometimes you can do some, injecting some local anesthetics and steroids to actually relieve the entrapment, all right, and reduce the pain over the area. Now, but whatever it is, you have to remember any intervention that you do in a chronic pain, most of the time it doesn't give a lasting effects. What's the aim of intervention is actually to actually help the person manage the pain for a while before they get used to it or and get back into their functional goal. Yeah.
Okay, got it.
Yeah. So these are some of what I've listed here are a lot of medical jargons, but basically these are some of ways that we can use to treat and to help the patient with chronic post-surgical pain.
Okay. If you guys have any questions, we're about to go into Q&A, so please type in the comment section. Yeah. And moving along, I think there's two more types to manage chronic post-surgical pain. I think it's surgical management, right? And non-pharmacological.
Yeah. So I think surgical management is you have to go back to the surgeon back again. I we as anesthetists, we don't do this, but sometimes you can go back to, you may need to go back under the knife to relieve the pain. Say, for instance, a neuroma excision. So you have neuroma means it's like neuroma occurs after a nerve is partially or completely disrupted by an injury. So it's like a ball-shaped mass at the site of injury. It's basically nerves, all right, in a clump like that. So sometimes that is the cause of the pain, and if you have to excise the neuroma, you have to go under the knife again and then remove that, and that may actually help you with the pain. And for instance, if you go for inguinal hernia surgery and the patient has a lot of pain after that, so normally in inguinal hernia surgery, they put in a mesh over there, to prevent that hernia from reoccurring again. So maybe that mesh has to go to remove the mesh in order to treat the pain. So sometimes, at times when you can't handle the pain, but you have to speak to the surgeon back again, and then maybe discuss these options. Yeah. So those are surgical management in that sense. Yeah.
Okay, got it. And non-pharmacological management.
Okay, so now I think if you ask me what's the most important management for CPSP, this would be it. Because you have chronic pain, and chronic pain is going to last. All right, and the best way to manage this are looking at physiotherapy and looking at using psychological intervention. CBT is like a cognitive behavior therapy, where you need the help of a psychologist to help you perceive and think differently of your pain. So that you can help. It basically just to help you manage the pain. Yeah. So I think because if you're going to use pharmacological treatment, are you going to take it for the rest of your life? You're going to take medications for the rest of your life just because of that. So you want to not take too much of medications. So you want to use other methods, and these are one of the other methods that can help you. Yeah.
Okay, got it. I think there's a question on that, but let's go into a summary, because there was a lot of knowledge shared just now. If you were to summarize everything, how do we treat CPSP or chronic post-surgical pain?
Okay, I think in order to treat this pain, it's just not one way. All right, you have to use medications. At times, you will do interventions. A lot of non-pharmacological methods of self-management of pain. Okay, now what does the biopsychosocial approach to pain management tells us? All right, those days, back in the day, they used the biomedical approach. If someone has pain, there must be a problem with it, and they must treat the problem, and the pain will go away. That's the general thinking. All right, but these days they don't find that anymore already. They talk about when someone has pain. Yes, there's a biological cause to it. They may have genetic factor. They have something which is the disease itself is giving you that pain. But then remember, the definition of pain tells you there's the psychological component, there was the emotional component, all these things, right? So then see, you want to treat pain, you have to look into other things as well, the social part of it, the psychological part of it, where how you want to look at what's their mood, what's their expectations. Are they catastrophizing? Catastrophizing means even a small thing they think is something bad happening to them. Are they having any stress? How are they coping with it? So you want to look at the psychological point as well. And of course, there's also social problems as well that can increase the pain. So if a lot of patients come to me in my pain clinic, and sometimes when you actually look in the social background and all, they have a lot of pain. They have flare-ups of their pain. When you look into the social background, they're either going through some financial problems, they're going through some divorce, something like that, which is disturbing them, or they got some problems with their work situation, which is disturbing them. Their bosses are not very, very hard on them, so their pain adds up. So this sort of thing, now we have to start thinking of when we start treating pain, we should look into all these other factors as well, and just not just focused on why you're having the pain or what is going on there. When someone has chronic pain, especially not acute pain but chronic pain.
Chronic pain, yeah. Very, very interesting, I have to say. Thank you so much for that. I think I just had like a complete understanding of the whole thing. So thank you so much. Let's go into a Q&A, because there's quite a few questions that people want to know. Let's see. The first question is from Sakina. Doc, how much painkiller is too much in one day? I have a meniscus tear and it is painful, especially at night. Can she rely on painkillers in order to get a good night's sleep? This is from Sakina. What's your advice, Doc?
Okay, how much painkillers is too much one day? I mean, there's always a maximum dose on any painkillers you can take.
Okay.
And normally when doctors use painkillers, they use this called a multimodal approach, So what they do is they don't just give you one painkiller and go up on the dose until it's maximized or go overdose on it. They tend to use different types of painkillers so that you reduce the dose of each painkillers and, gives you a better effect. So, if you have a meniscus tear and it's really painful, I'm just wondering, maybe I'm not sure if that person has gone. I mean, Saki has gone and seen a doctor to make sure that this meniscus problem has been sorted or not. I mean that's the first thing we'll do rather than rely on painkillers for a long time. Yeah, because every painkiller will have its side effect, and we wouldn't want to be relying on it for a long time just to get a good night's sleep. I think you want to look at the underlying first. Yeah.
Okay, got it. So basically go and see doc. That's what I would advise, right? Okay. Next question is from Suraya. I hope that answers your question, yes, Sakina. Suraya is asking, if unable to pinpoint the cause of the pain, can you still suggest a pain management plan? What do you say, doc?
Yeah, so that's how chronic a lot of chronic pain is like this. Many patients who come with pain, they can't pinpoint what's the problem. Where is the problem? There's if they can't pinpoint and everything has been ruled out, okay, when they don't know what the problem is and everything, you've gone through a lot of scans, you have seen many doctors and and trying to treat and everything, you can't treat, then you have to then you just have to come up with a pain management plan. That's where I come in. So we look at different ways of managing your pain then. Yeah. So depends on what you have. If you can do interventional, we do interventional. If you can't, then we look into pharmacological and non-pharmacological approaches. Yeah.
Okay, got it. Next question by Sakina again. How does one prepare oneself for post-surgery pain? If you are mentally prepared and embrace the pain, will that ease the situation to a bearable degree? Great question, I think.
Yeah. It's a difficult question to answer actually. But how do you prepare? I think a lot of it is what's your rapport with your surgeon, your anesthetist. I think that you build a good rapport with them. Tell them what your expectations are after the surgery, right? Sometimes it's good to have a good plan. So whenever I see my patients preoperatively, I will build a plan with them, especially complicated case. What do we do postoperatively? And if you are going to see anybody, going for a surgery or so, and you have no, I think the first thing you should ask the anesthetist when they come and see you is what's your plan for my post-operative pain, and then it can be discussed. We come up with a good plan. Are you comfortable with it? Am I comfortable with it? And if you are, we agree on it, and then we can continue. Then we can proceed and do that. So normally, what I do is I ask my patient, what do you expect? You want zero pain? Or you want tolerable pain. Zero pain is something I cannot completely cannot give you a guarantee on that. But we give you something tolerable, we give you something tolerable so you could have a good night's sleep. That's important. You want to have if you've gone for some kind of orthopedic surgery and you need physiotherapy, you need to be able to do physiotherapy and you should not be in pain while you're doing physiotherapy. So those are goals that we have to speak to our patients first before we proceed. Yeah.
Okay, got it. I think that's a brilliant answer. Norlisa has a question. Doc, what is your suggestion for pain management of a keloid scar that is still sensitive after 5 years of surgery?
So this is a form of chronic post-surgical pain.
Yeah, definitely. Yeah. I knew that based on today's session.
So I think again, it is difficult for me to tell to tell you offhand like this how to manage, but I think you need to see a pain physician first, or in fact actually go back to the initial doctor that did the surgery and ask, why do you think this is happening first? From there, normally how you get to a pain physician is when they can't sort out the pain, that's when they come to a pain physician to manage the pain then.
I see.
So you can,
Okay,
yes,
okay.
they can, like Noraliza, she can use based on what I have spoken today, the pharmacological way, the non-pharmacological way, and also the interventional way. So it depends on where the pain is, how the pain is, what type of pain she has, and all. Then we can formulate a plan for her.
Okay, got it. Very interesting. Suraya has another question. Can the pain ever be fully eliminated? I think you somewhat answered, but I want to hear it again.
If it's chronic post-surgical pain and you have ended up with a pain physician, I don't think so. It's
Wow.
again, we want to it's what's our goal again when you talk about managing chronic post-surgical pain. It's a functional goal rather than we don't want to be, you want to get the pain down to something that someone can tolerate and function. That's our goal should be, not if you're looking at fully eliminating pain and all this, then it's a far-fetched kind of goal, I think.
It's a far-fetched. Okay. I have a question going back to Noor Aliza's question. Since the pain is still sensitive after 5 years, do a lot of people normally don't understand about chronic post-surgical pain? Is that probably what is the thing that a lot of people don't get? That they don't realize that it is under chronic post-surgical pain?
Yeah, I mean, this can be a form of chronic post-surgical pain. I mean, like what Norisa said, and it's probably, yes, they don't have enough. I mean, they don't know that this is chronic post-surgical pain and don't know who to go back to see, and get help for this thing. But then again, like I said, there are a lot of people having this type of pain and they tend to tolerate it well and just get on with their life, and it's not disturbing them. They can sleep and everything. So it depends on what your expectations are. Yeah. So if Noraliza has this sensitive area, and if it's bothering her a lot, she can't sleep, she can't she can't eat because it's over her jaw or something like that. The kind of thing, you can't do your daily activities of living, then come and see us and we can help out.
Okay, I'm going to take one question before we go to the quiz. Another Nina is asking you a question. Nina Isabakiyeva is asking when we need to do MRI after surgery just to be sure all is in order and still have some pain after 7 weeks post-op.
Okay, whether you need to do an MRI or not, you need to ask your primary doctor who did the surgery, all right? You can, it depends on what you do. I mean, if you have done a knee surgery, say a knee arthroscopy or scope, and then probably you need to repeat MRI. But again, talk to the doctor, because you know why? The person who did the surgery would know what was going on in there. What did he do, or he or she do? So always go back to the initial doctor and ask, why am I still having pain? Is there a problem in there or not? Let them investigate first. All right. If it's nothing to do with the surgery, then, and it's already more than what the definition say, 2 months and all, then we start thinking of chronic post-surgical pain. Yeah. So go back to the doctor first. They will tell you, do you need to do any other form of imaging to recheck again? I think they should know. Yeah. So once all these have been investigated and they have not found anything, and they think they need pain management, and that's where my role comes in.
I see. Okay. Kind of thing. All right. So now let's take a break from the questions. First, let's go into the quiz, right? So as mentioned earlier, we've got some basic health screening vouchers up for grabs, but what do you guys need to do in order to win? First, you got to be sure to share this video out at least 3 times, and remember to set the share post to public so that everyone can see. Next, you need to answer 3 questions that will be showing on screen in a single comment, and you are on your way to win the prizes. So let me repeat that. First, share the video out 3 times, and remember to set the post to public so that everyone can see. And secondly, answer these 3 questions that we're going to share on the screen in a single comment, in a single line, yeah? And we will select the first 3 winners based on speed, the correct answers, and shared posts. So are you guys ready? Let's have the questions. First question is, there are 5 different types of pain, true or false? Pre-operative and post-operative factors are the only 2 areas of prevention we look into for management of chronic post-surgical pain, True or false? That's the second question. And the third question is, regional anesthesia is the only way to manage chronic post-surgical pain. True or false? Let me repeat that. There are 5 different types of pain. True or false? Pre-operative and post-operative factors are the only 2 areas of prevention we look into for management of chronic post-surgical pain. True or false? And the third question is, regional anesthesia is the only way to manage chronic post-surgical pain. True or false? Okay, let us know what the answers are. Take a guess. Okay, going back to the question, I think Cecilia has a question. Is there a way to increase our pain threshold? I think this is a brilliant question. Is there a way to increase our pain threshold, or is that fixed for each human body? And already we all have different thresholds of pain, right?
I don't think you can increase your pain threshold, but I mean, or do it in, or fix any part of your body for that matter. But pain. One perceives pain is not influenced by their, apart from the genetics and all these things. A lot of it is actually how their life experiences come out. It's a lot of how you grew up and how you see your parents and how you see your environment perceive pain, and that's what you thought pain was, and that's how you perceive pain as you grow up. So a lot of it is your life experiences and all. So if you really want if you really want to fix something, to me, I think the psychologist would be the best person to help you in that sense, because it's more of a perception kind of thing. Yeah. But otherwise, I really don't know how to increase your pain threshold. Yeah.
Okay, so basically seeing a psychologist could actually help, because it goes back to our early childhood experiences and how we perceive pain, right?
Right.
Okay.
Yeah. In fact, I think management of chronic pain, a lot of management of chronic pain is actually, we use the help of psychologists to help us out.
Wow. Okay. We will need to have a chat on this. Very interesting, I have to say, Doc. Okay, let's go back to some questions while we wait. I'm waiting for to know who the winner is, but we have a question from Eliani Hussein, whose question is, I just had brain surgery done on 16/11. That's quite recent. So it's post-op day 8. Now already at home for recovery. Was given PCM and was told to take it when needed. But I'm afraid I overtook currently 3 times a day. Am I doing good? What is PCM, Doc?
Yeah, that's paracetamol.
Okay.
Panadol. Yeah. So
Panadol, okay.
So the maximum dose per day for Panadol is 4 grams or 8 tablets. You take it 6 hourly. In fact, some even go 4 hourly, but I wouldn't recommend for pain you use 4 hourly. In fact, for long. So I mean, if she's using 3 times a day, and assuming that she took 2 tablets 3 times a day, that's okay.
Okay. So you're doing good, Al. Kind of thing. Yeah. So yeah, any other questions, let us know. But I have some questions. You mentioned a lot about psychology. When do you have instances or cases when you've got your patients working with psychologists that the pain management is better and they have a turnaround of on their chronic pain? Are there any stories that you can share, Doc?
Yeah, I mean, I think the best thing is to share my experiences in Selayang Hospital. When I was in Selayang Hospital, it was the pain center of the country. It's where they started the first pain clinic, and then they came up with, and we work hand in hand with the psychologist over there. And the psychologist comes during our clinic visits. I mean, they come to sit with us in the clinic, and we see patients together. And yeah, we have seen, to give you a story offhand, I can't, but there are patients where actually we help them to manage the pain well, basically. So these patients, they still have pain, but they know how to manage it. They learn techniques that they can use themselves to manage this pain. So some of these techniques are like distraction. That's one of it. Distraction. if they have so much of pain, they distract themselves, they do something else. That's one way of handling chronic pain.
Okay.
And then yeah, so the psychologists really help. There are instances even where I'm seeing over here as well. I've engaged with psychologists outside to help us, psychologists to help out with our pain management.
Okay, and how long does it normally take to see a difference? Usually, if you work with your patients,
it takes time. It's
takes
not
time,
that
okay.
easy, because it's about changing the way you think about this pain that you feel, and it's not easy to change the way someone thinks straight away. So it takes months to even sometimes a year. So yeah.
Wow. Okay. So basically, it's a recovery journey, I would say. Yeah.
Yes.
I've got 2 more questions to end it off before we go off. What's the biggest mistake that a lot of people or most people make when it comes to chronic post-surgical pain?
Okay. So like I've said, if always speak to your anesthetist and surgeon about your post-operative pain. Okay. You don't want to just leave it hanging, and so we don't know, the surgeon or anesthetist doesn't know what your expectations are, and you think, and you have some expectations, and we don't give you enough or something like that. So these are miscommunications, and then you tend to have very bad post-operative pain, and eventually becomes it goes on to become chronic post-surgical pain. I think the other thing is to know that this, basically education. Everybody has to be educated and know that, these such things can happen as well. Yeah. So not only the patient themselves, the surgeons, the anesthetists, the nurses, allied health professionals, they need to know that there's something such as chronic post-surgical pain. When you know and anticipate something, how you start looking and looking for factors of how to prevent it. I feel that's how it is.
All right, fantastic. I think that's, I was going to ask you the 3 tips, but I think you basically put the tips out there already. So thank you so much. And I think we have our winners here. So before I announce who the winners are, I'm going to go through the questions and we're going to get the right answer. Doctor's going to help us. So for the first question, there are 5 different types of pain. It's actually false, right, Doc?
Yeah, false.
Okay, there's actually 3 different types of pain, right? I think. Yep.
I think.
And, okay, and pre-operative and post-operative factors are the only 2 areas of prevention we look into for management of chronic post-surgical pain. The answer is false as well, right, Doc?
Yeah. Right.
Okay.
So you have pre-operative, intraoperative, and post-operative as well.
Okay, that's 3. Okay. Regional anesthesia is the only way to manage chronic post-surgical pain. Answer
false.
is false, because there's 5, right?
There's pharmacological methods, non-pharmacological methods, interventional methods. Regional anesthesia is part of an interventional management. Yeah, it's an interventional, part of interventional. Yeah.
Okay, so there's more than 1. Let's just put it that way. So the answer is false. All right, and our winner is Cecilia Chang, Suraya Aziza, and Sakina Al-Junid. Congratulations to our winners. You guys basically get to win 5 health screening vouchers. So congratulations. So what's going to happen to all our winners is that we will be contacting you after this within a day. So do check to get all your details. So do check your Facebook Messenger, right? Congratulations, Sakina, Soraya, and Cecilia. Well, there you have it, ladies and gentlemen. We hope you had a super insightful session. I really did. What are some of your biggest learnings? Please let us know in the comment section. For me, definitely it was about psychology, playing a huge part in our life experiences as well, and how we perceive pain, and of course the different types of pain. And that I think we need to create awareness on this, right, Doc? That
Yes.
a lot more people need to understand and to know that surgery, there's pain after surgery. It doesn't happen just after surgery. A lot of cases that happen, it also starts from before the pain, before surgery, during and after, that sort of thing. So thank you so much. I definitely learned a lot. So let's give Dr. Rushin a round of applause before we say goodbye. So thank you, Doc. Thank you very much for today. All right. Okay, bye. Thank you.
Bye.
All right. So what is it that you guys got from today? Let us know. Please let us know in the comment section. We'd love to hear from you. But you know what? That is all the time we have for today. We hope you learned a lot of things. And if you know someone who will appreciate the tips, info, and insights from today's show, please share this video out and tag them, because you never know who it's going to make a difference to. All right. And make sure you give us a like and lots of love while you are at it. Thank you so much again. Till then, take care of yourself and of each other. We're going to see you in the next episode. Till then, bye.